is a specific kind of fear that happens when you live with a complex chronic illness and your body starts doing something completely new. We are looking at a piece today by Rick Dissler from My Adrenal Life. He is writing about the overlap between adrenal insufficiency and serotonin syndrome. And the whole premise is that when something goes wrong, it is incredibly difficult to know which one has happened.
Because they look so similar on the surface. If you have adrenal insufficiency, you are already used to a certain amount of physical instability. You know what it feels like to be low on cortisol. You know the fatigue, the nausea, the way your blood pressure just drops out from under you. But serotonin syndrome introduces this entirely different mechanism that mimics some of those crisis signals, but requires a completely different response. And Dissler makes this point early on that I cannot stop thinking about. He says, the symptoms feel different, not just off, but unsettling in a way that is hard to put into words.
That is the exact phrase. Shaking, sweating, racing heart, those are autonomic responses. But if you are an adrenal patient, you might just think, I need more steroids. I am going into crisis. And if you treat serotonin syndrome like an adrenal crisis, you're not fixing the underlying problem.
Exactly. And you might actually be delaying the exact care you need. Serotonin syndrome, or serotonin toxicity, as it is more accurately called in clinical literature, is a predictable, dose-dependent reaction to having too much serotonin in your nervous system. It is not an allergy. It is not a rare idiosyncratic thing. It is literally just a mechanical overflow of serotonin. And the stakes are high. Data shows that in severe cases, the mortality rate for recognized serotonin syndrome can be around 11%, and half of those failed cases deteriorate within 24 hours of the symptoms starting. So time is absolutely a factor.
Which means the confusion itself is the danger. If the patient is confused and the emergency room doctor is confused, the clock is ticking.
Right, and think about what happens when an adrenal insufficiency patient walks into an ER. They have an emergency protocol letter. It says, if I am crashing, give me stress dose Soleucort immediately. And the ER doctors are trained to look for that adrenal crisis. They see the patient sweating, confused, tachycardic, and they think endocrine emergency. They might not even look at the medication list to see the antidepressants or the migraine meds that actually triggered a toxic serotonin overload.
It is a cognitive blind spot. The diagnosis anchors the physician. Let's pull back and define serotonin syndrome properly. It is usually categorized into 3 buckets.
Right. The clinical presentation triad. You have mental status changes, which means agitation, restlessness, profound confusion. Then you have autonomic hyperactivity. That is the heavy sweating, the racing heart, the sudden spikes in blood pressure, and sometimes a really high fever. And then the third bucket, which is the most critical for actually telling it apart from an adrenal crisis, is neuromuscular abnormalities, tremors, muscle rigidity, and specifically clonus.
Clonus, that repetitive rhythmic jerking of the muscles, that does not happen in a standard adrenal crisis.
No, it does not. And that is the key. Adrenal insufficiency might make you weak, it might make you shake because your blood sugar is tanking, but it does not cause those hyper-reflexive, rigid, rhythmic muscle spasms. But if you're the patient, sitting in your living room, feeling your heart race and your skin sweat and your brain get foggy, you are not performing a neurological exam on yourself. You just know you feel catastrophic.
So Dissler is writing this to say, pay attention to the specific flavor of the disaster. If you're twitching in a way you haven't before, if your muscles feel rigid, that is a different data point.
And the timing. Serotonin syndrome usually hits fast, usually within 20 to 24 hours of a medication change. You start a new SSRI, or you take a triptan for a migraine on top of your daily antidepressant, or you take cough medicine with dextromethorphan, and within hours, the toxicity builds. Adrenal crisis can be fast, but it often has a slightly longer runway. A stomach bug over a few days, a slow drain of cortisol. Though, of course, the sudden trauma can trigger an adrenal crisis instantly.
I want to dig into that medication piece, because Dissler makes a point to say this is not about adrenal insufficiency making you biologically more prone to serotonin syndrome. The disease itself does not cause the vulnerability.
No, it is the treatment landscape. Patients with complex chronic illnesses just take more medications. They see more specialists. The endocrinologist handles the hydrocortisone. The neurologist handles the migraine meds. The psychiatrist handles the anxiety meds. The primary care doctor gives them antibiotics, and suddenly you have this massive web of pharmacology.
The polypharmacy trap. It is a structural problem in modern medicine.
Exactly. And let's be clear, serotonin syndrome is actually relatively uncommon in the general population, but it is vastly underdiagnosed. The incidence rates are hard to pin down because mild cases just get written off as a bad reaction to a drug or increased anxiety. But when you have a patient who is already medically fragile, the threshold for that bad reaction turning into a systemic cascade is just different. Their reserves are lower.
Let me stop you there, though. I don't know if that feels entirely right. The idea that the threshold for the toxic reaction is different just because they have adrenal insufficiency.
How so?
Serotonin toxicity is a mechanical receptor issue. If the serotonin receptors in the central nervous system are flooded, they are flooded. Whether you have Addison's disease or you are a perfectly healthy 20-year-old, the Hunter toxicity criteria for diagnosis, which is the gold standard, it has like an 84% sensitivity. It relies on the presence of the drug and the physical signs like clonus. The adrenal status doesn't change the receptor pharmacology.
Actually, no, you're completely right on the pharmacology. The receptor overload happens exactly the same way, but what I mean is the consequence of that overload. If a healthy person gets mild serotonin syndrome, their autonomic nervous system goes haywire. They sweat, their heart races. Their body is under massive physiological stress. A healthy body produces a massive surge of cortisol to handle that stress. An adrenal insufficiency patient literally cannot do that. Their adrenal glands are broken. So the serotonin toxicity acts as a massive stressor that then triggers an acute adrenal crisis on top of it.
Ah, so they don't just mimic each other, they can happen simultaneously. The serotonin storm causes the adrenal crash.
Yes, and that is where the clinical picture becomes an absolute nightmare for an emergency room doctor, because the patient is legitimately in an adrenal crisis. Their blood pressure might be crashing from the cortisol deficit, but they are also exhibiting the hyperreflexia and the agitation of the serotonin toxicity. If the ER just pumps them full of Solucort and walks away, the serotonin is still frying their nervous system. If they only look at the neuromuscular stuff and ignore the cortisol, the patient goes into hypovolemic shock. It requires this dual-track thinking that is incredibly rare in a fast-paced trauma set.
Which puts the burden entirely back on the patient, which is exhausting. You're essentially asking someone who is actively experiencing a neurological and endocrine emergency to be their own differential diagnostician.
And Dissler is very careful to say the goal is not self-diagnosis. The goal is recognizing when something is different. But you are right, there is something almost cruel about the reality of chronic illness where you have to maintain this hyper-vigilant catalog of your own bodily sensations. You have to know the exact flavor of your normal suffering so you can articulate when it changes.
There is a case report in the literature that actually perfectly illustrates this exact diagnostic trap. A patient with Cushing's, which led to secondary adrenal insufficiency.
Yes, I read that one. It was published in Frontiers in Psychiatry. It is a terrifying sequence of events. The patient had all this severe anxiety, which was initially caused by the Cushing's, the excess cortisol, but they were treated with multiple psychiatric medications. Then they had surgery to remove the pituitary tumor, which cured the Cushing's, but left them with secondary adrenal insufficiency. So now they have no natural cortisol. But they were discharged still taking the same heavy doses of antidepressants and anxiolytics. And within a week,
they end up in the ER.
Right. High fever, racing heart, impaired consciousness. The doctors initially looked at her chart, saw recent pituitary surgery, adrenal insufficiency, and assumed it was an adrenal crisis. But the physical exam showed tremors, muscle rigidity, and dysarthria, difficulty speaking. Those are not cortisol symptoms. A psychiatric consult finally figured out that the combination of her 3 antidepressants had pushed her into serotonin syndrome. If they hadn't caught those specific neuromuscular signs, they would have missed it completely.
That is the exact danger Dissler is warning about. The medical team anchored on the most obvious catastrophic label in her chart, the adrenal insufficiency. And you can't even really blame the ER doctors. In an emergency, you play the odds. Adrenal crisis kills quickly if untreated. But this is why tracking medications is so critical. Dissler points out that serotonin syndrome most often happens when multiple serotonergic drugs are combined, and it is not always just 2 antidepressants. It is an SSRI and a triptan for a migraine. It is an antidepressant and tramadol for pain. It is even over-the-counter stuff like dextromethorphan and cough syrup. You get a cold, you take some NyQuil on top of your Lexapro, and suddenly your reflexes are misfiring.
That feels like something that should be caught by the pharmacy system. Every time I pick up a prescription, there's an automated interaction check.
I hear you, but I keep getting stuck on the fact that the pharmacy system is fundamentally fragmented. Yes, if you fill everything at one CVS, the computer will flag a major interaction. But patients with rare diseases often use specialty pharmacies for their niche medications and a local pharmacy for their antibiotics, and then they buy St. John's wort or cough medicine over the counter. The system doesn't see the whole board. And even when it does flag an interaction, doctors override them all the time because the risk is deemed acceptable for a specific patient, until it isn't.
So the safety net has holes, massive ones, which brings us to how a patient actually communicates this without sounding like they are consulting Dr. Google in the ER.
Dissler offers a really elegant script for this. He suggests framing it purely in terms of changes and timeline. You don't walk in and say, I have serotonin syndrome. You walk in and say, I have adrenal insufficiency, but these symptoms started right after a medication change. And this muscle jerking feels completely different from my normal low cortisol symptoms. You give them the data, but you let them connect the dots.
You are handing them the puzzle pieces, but letting them feel like they solved it.
It is an exhausting kind of diplomacy, but it works. Because if you come in demanding a specific toxidrome diagnosis, human nature kicks in and the clinician might get defensive. But if you just clearly highlight the neuromuscular stuff, my legs are twitching rhythmically, and I just started this new cough medicine yesterday, you trigger their training. They know about clonus. They know about the Hunter criteria. You just have to make sure the noise of the adrenal insufficiency doesn't drown out those specific weird signals.
We are demanding an incredible amount of clarity from people who are actively experiencing impaired consciousness. That is the paradox here.
It is. There is something genuinely unsettling about the fact that your survival might depend on your ability to articulate your own neurological decay while it is happening. But that is why Dissler wrote the piece. It is about building the vocabulary before the emergency happens. If you read this article on a random Tuesday and you internalize the idea that muscle rigidity and rhythmic jerking is not an adrenal crisis, then maybe 6 months later when you are sweating and shaking, that one fact cuts through the brain fog.
It is preloading the protocol. You're installing a tripwire.
Exactly. You don't need to know the pharmacology. You just need to know your own baseline well enough to say, this is not that. This is something else.
We need to talk about the treatment because the divergence is sharp. If it is an adrenal crisis, it's IV hydrocortisone and fluids. If it is serotonin syndrome, what actually is the intervention?
The very first thing always is discontinuing the serotonergic agents. You have to stop the overflow. After that, it is mostly supportive care. IV fluids, cooling measures if their temperature is spiking dangerously high. For the agitation and the muscle rigidity, benzodiazepines are actually the first-line treatment. They calm the central nervous system down. In really severe cases, they might use specific serotonin antagonists like cyproheptadine, but often just stopping the drugs and giving a benzo is enough to let the body clear it out. But again, think about the adrenal patient. If they are simultaneously in an adrenal crisis because of the stress of the toxicity, they also need that IV hydrocortisone. It is not an either-or scenario.
They need the brakes applied to the serotonin and the gas pedal pressed on the cortisol.
That is a perfect way to describe it. And if the clinical team misses either half of that equation, the patient remains in danger. It requires a level of multi-system thinking that is the hallmark of really good acute care. But it is also why patients feel so vulnerable. You're trusting the system to see all the moving parts.
Which is why the conversation around chronic illness always seems to return to this idea of radical self-advocacy, not by choice, but by necessity.
And there is a grief in that. Diesler acknowledges it at the end of his piece. He says, "You are not expected to figure this out alone, and you are not alone in navigating it. But the underlying reality is that often you are the only one in the room who holds the entire map of your medical history. The endocrinologist has a piece. The ER has a piece. You have the whole thing."
Drawing the threads together here, we are looking at two life-threatening conditions. One is an absence of a necessary hormone. The other is a toxic overflow of a neurotransmitter. They look identical if you are only looking at the sweat and the fear. They look completely different if you look at the muscles and the medication list.
And the bridge between those two perspectives is the patient's ability to say, this feels different. That is the whole game. Trusting the unsettling feeling that the current crisis does not match the historical data. Rick Dissler's work over at My Adrenal Life is trying to give people the permission to trust that feeling and the specific words to use when they do.
If this kind of breakdown helps you navigate the medical system a little more clearly, send this to someone who might need the vocabulary. Keep paying attention to the details.